Hello and welcome to today's webinar, Complete EPA, Taking the Pain Out of Prior Authorizations. Before we get started, I'd like to announce a few brief housekeeping details. Today's session is being recorded and an online archive of today's event will be available a few days after the call. You will receive an email from AHIP that will ask if you would like to receive the archive. Please respond to the email if you would. I'd like to remind you of AHIP's antitrust statement and ask that you reference it in the Handouts tab. The antitrust statement prohibits us from discussing competitively sensitive information. Please keep in mind that you may ask a question at any time during the presentation by typing your question to the chat box located in the lower left-hand corner of your screen, and then click Send. You can adjust the size of the slides to fit your screen by clicking on the Scale button located in the upper right-hand side of your screen. We're very fortunate to have with us today Joseph Delisle, Business Manager at Surescripts with responsibility for electronic prior authorization, and Scott Furletti, Vice President of Agadia Systems. And now I'd like to turn the floor over to Mr. Delisle.
Thank you. So today we're going to talk about electronic prior authorization and how it can benefit both providers and PBMs and health plans. So I'm going to take the provider perspective and take you through Complete EPA, the EHR integrated EPA solution. And Scott Furletti is going to take the PBM health plan perspective and take you through Agadia's PA Hub. The slide here, it is the medication management lifecycle, and this is it in its ideal state, with PBMs and health plans sending physicians the accurate, timely information they need to make the best prescribing decisions for their patients. That prescribing decisions with the correct information allows the physician to send clean, pre-approved, error-free prescriptions to the pharmacy and delivering the most effective, cost-efficient medication for patients who can pick their medications up without any delay. This, again, is an idealized state. It exists in pockets today, but this is the overview. This is the situation that we are all working to bring about, delivering that information from PBMs and health plans to physicians at the point of care so they can make those prescribing decisions that are the best for their patients. So we're here to talk about prior authorization, and that's part of the information flow from PBM and health plan to physician. Prior authorization is important in the grand scheme of things, making sure physicians are prescribing the most effective, cost-efficient medication for their patients, but it's also costly, and it's costly for everyone involved in the process, from physicians who are spending up to 8 hours per week processing prior authorization requests at a cost of sometimes up to $10,000 per year, to PBMs and health plans at a cost of about $20 to $25 per prior authorization submission. Prior authorization also impacts pharmacies, who today are really the tip of the spear in the prior authorization process, often the first to know that a prior authorization is required, dealing with patients who are there to pick up their medications but can't. Pharmacies today are spending on average about 4 hours per week, each pharmacist dealing with prior authorization requests. And then, of course, there's the impact on patients, 20 to 30% of whom never actually get the prescription that was originally prescribed to them. Some patients drop completely and don't get the medication. Others have an alternative prescribed. And for those patients who do end up getting the medication, the average waiting time for about 2/3 of them is 2+ days. So as you can see, prior authorization is an issue, and part of the issue is to do with the process as it exists today. And apologies for the slide, it's rather confusing, but that's the process as it is today. It's a confusing, time-consuming manual process that results in inefficiencies for prescribers, for PBMs and health plans and pharmacies, and at the end of the day, it makes patients wait for their medication. So the process as it exists today generally starts at the pharmacy. So the physician will send the new prescription to the pharmacy. The pharmacy will attempt to adjudicate it and be denied with a prior authorization requirement. Then the pharmacy will turn around and let the physician know that the PA is required, either by a phone, fax, an easy button within their system that lets the physician know that a PA is required. And there the physician has a choice. They can prescribe a different medication that maybe doesn't require a prior authorization, and as we saw on the last slide, that does happen, or they can go through the process of processing a manual prior authorization, which can mean a phone call to the PBM or health plan, which takes an average of 30 to 45 minutes, or filling out a prior authorization form that they might download online and fax in. That process can take, again, as we saw again on the last slide, over 2 days before they get an approval, before the pharmacy can fill the prescription and the patient can pick it up. That is prior authorization as it exists today, but we're here to talk about an easier way. And that easier way started with the NCPDP EPA standard that Complete EPA is built on. And really what it is at a high level is enabling a physician through their EHR to communicate details of the prior authorization electronically with their patient's PBM or health plan right within the EHR, essentially in real time, so that the physician can send that prescription off to the pharmacy. It's pre-approved, it's error-free, the pharmacy can dispense that medication, and the patients can go pick up their medication without delay and start their treatment. So Complete EPA is Surescripts' electronic prior authorization product. We've been working on electronic prior authorization for over 4 years, starting with a pilot, stood up with Caremark and a couple of other participants to really learn about the prior authorization process. And a lot of those things that we learned about what providers want in an electronic prior authorization process, we implemented in Complete EPA, starting with pre-populating patient data. If anyone's ever seen, and I'm sure you all have, a prior authorization form, the top half or so of the first page is filled with demographic information, letting the PBM or health plan know who the provider is, who the patient is, and what medication is being prescribed. Well, all that information already exists within the EHR. So what we decided to do was extract that information automatically from the EHR. We're sending that information error-free to the prior authorization rules engine. Whether the prior authorization rules engine exists at the PBM or at the health plan or with a third-party processor like Agadia, that information is able to be transmitted electronically right from that EHR, saving the physician or the nurse or the office manager, whoever's processing the prior authorization at the provider practice, the time and effort of entering in all that information again. Entered it in once in the EHR and a second time on the prior authorization form. So we cut out that step, make the process more accurate, and deliver the information to that prior authorization rules engine that lets them, that prior authorization rules engine, turn around and present the physician with questions that are really specific. Not a prior authorization form that might cover a number of plans and a whole class of medication, but they're able to send a question set that's specific to that particular patient's health plan and the medication that's actually being prescribed, limiting the number of questions that a provider actually has to answer to process the prior authorization. So what I want to do now is take you through really a workflow, a sample workflow of an electronic prior authorization. And it's a process that really starts with e-prescribing itself. Electronic prior authorization and Complete EPA specifically is built on the rails of the e-prescribing network. It leverages very heavily the benefit and formulary information that Surescripts is already delivering to providers at the point of care, and using that connectivity to then process electronic prior authorizations between the physician and the prior authorization rules engine. So it starts with a patient visit at the provider practice, where their EHR, the provider's EHR, is going to look up to see where that patient has their pharmacy benefit coverage. That information is going to come back from the PBM and populate the information in the EHR and really let the EHR know which formulary file to look at when the provider is e-prescribing. So that when I go to the doctor and the doctor wants to prescribe Nexium, the EHR already knows where I have my pharmacy coverage and what formulary file to look at. So for my specific case, the EHR is going to reference the formulary file that says Nexium requires a prior authorization, and the EHR is going to notify the provider in the e-prescribing workflow that a prior authorization is required. So here is where the benefits of EPA really start to kick in. And on the EHR side, they're going to extract all that demographic information that we talked about last slide and send it to the PBM or the health plan or the third-party processor, who's ever processing the prior authorization. All at the touch of a button, or in some cases automatically. That information gets sent, and the PA processor can look at that information, match it to their database, and run a check first to see if a prior authorization is really required. Because one thing about the formulary file is that it's representative. It is not at the patient level. So delivering that demographic information, letting the PA processor know who exactly the patient is and what medication is being prescribed, allows them to run a first check to see if a prior authorization is actually required. And if it's not required, even though the formulary file says it is, they can respond with a message that says prior authorization is not required. And at that point, the EHR can release the prescription, send it off to the pharmacy, and the patient can go pick up their meds. But if a prior authorization is required, the PA processor is able to match that patient, that drug, with a specific question set that needs to be answered in order to make that approval or denial decision, and send only those questions that need to be answered into the EHR. Again, cutting down on time at the provider office of answering irrelevant questions. And the provider, when they get that question set, is able to answer it through their EHR without leaving the EHR to stay on hold via phone call, or fill out a fax form and send it in, or visit an external portal. Everything is able to be done within the EHR. The question set is able to be returned. And again, it's developed in a way that it's discrete data elements so that it can be input directly into a database, and an approval decision, if it's an approval, is able to be sent in real time back through the EHR. And again, when that approval comes in, the EHR is able to release the medication to the pharmacy, and the patient can pick it up. So in the ideal workflow, the prospective workflow, eligibility and benefits are referenced. They trigger the prior authorization. The PA is done electronically by the provider in the EHR. The PA processor is able to respond back into the EHR. The EHR will release the medication to the pharmacy, and the patient can pick the medication up. So that is prior authorization in its ideal state, the prospective workflow. That complete EPA and NCPDP standard also supports retrospective prior authorizations. Those are cases where the prescription does get to the pharmacy before the prior authorization is done, and also supports situations where the prescription is not even sent electronically. This is common in controlled substances. It's really all the provider has to do is enter in the medication information with the patient and initiate the prior authorization request for it to happen electronically. So one of the things that's driving EPA adoption right now are these state requirements. And there are a number of different states that require electronic prior authorization in one form or another. The big ones that just had their date pass earlier this year and late last year are North Dakota and Minnesota. So there's no surprise that those are the two states where we see the most uptake on the provider side. But again, there are a number of other states here. So the states in orange on this slide require some form of electronic prior authorization, whether it is the NCPDP standard or another means of processing electronic prior authorizations. Other states have uniform prior auth forms or other policies and limitations. So what I want to do now is give you a quick update on where Surescripts' EPA network is. We went live just over a year ago, and we've seen some really great things in the year since then in terms of EHR adoption, providers using, and transactions. So on the top part of the screen here, we see our network participants and usage. So the left column are EHRs on the network. And live today, we have EHRs with just about 82,000 e-prescribers live on Complete EPA today. We have 340,000 or so prescribers who are on EHRs that are at different stages of the implementation process. with most of those set to go live by the end of the year. On the other side of the network, we have 7 PBMs live right now that account for just about 85% of covered lives. And in addition to the PBMs, we have third-party processors live, like Agadia, who you'll hear from later. And what those two sides of the network mean is the left side, the EHR side and doctor side, are able to send volumes of EPA transactions to the PBMs and the third-party processors that drive the cost savings on that side. The PBMs and the third-party processors make the availability of electronic prior authorization attractive to providers on the EHRs, so that a provider using Complete EPA has a really good chance of processing an electronic prior authorization through one of these 7 PBMs or 2 third-party processors like Agadia. That drives a good user experience, and that means providers will use it, they'll adopt it, and they'll use it frequently. Again, driving the cost savings on PBMs, health plans, and third-party processors. So we've seen really amazing growth just in the last 3 or 4 months. So the number of users has gone up 4x since the beginning of this year, and the number of transactions is up 6.5 times since the beginning of this year, speaking to the good user experience that the PBMs and the third-party processors are supplying to the providers on the other side of the network. And part of that user experience is how quickly are PBMs responding, and they're responding quickly. The median response time for a PA initiation request, that's that first transaction where we're sending demographic information, is 7 seconds. That's essentially real time, and they're able to respond back into the EHR that either a prior authorization is not needed, in which case the prescription goes off to the pharmacy, or they're able to respond with that question set, letting the user in the physician office know which questions they need to fill out before getting approval for that prior authorization. And I talked earlier about the question sets that can be specific. This stat here, the 50% reduction in required questions, really speaks to that. And part of that is what we call skip logic. And that's the ability for a health plan to structure a question set so that the next question that's displayed to the user is dependent on the answer to the first. So if I answer question 1, no, and maybe that means question 2 and 3, the health plan or the PBM doesn't care about the answers to those. So we just skip it, present the user with question number 4, allowing them to complete the forms quicker with less steps, increasing the utilization through on submitted prior authorizations. So that's the network update and where we are today. What we've learned over the last year plus is that it's not easy to change physician behavior. A lot of hands-on action is necessary, and at Surescripts we've done a number of different things across these 4 buckets here to drive physician adoption, awareness, and utilization. Starting with the left side of the slide, dedicated resources that we put into making the user experience good for physicians. We have dedicated account managers and marketing to help drive adoption and awareness of prior authorization, so the physicians know that EPA is available through their EHR. And we have an activation team that works hand in hand with EHRs and health systems to train their users, to make sure they understand what they're going to see under EPA and to manage expectations. And part of that is administrative support, providing weekly or biweekly reports to our participants on how they're performing on the network and how the opposite side of the network is performing so that we can optimize the user experience for both sides. And again, I talked about user training, so it's really broken down into 2 buckets, the end user training and then training the vendor or the health system trainers. And our activation team, again, works hand in hand with the vendor, so the EHR vendor or the health system, to make sure that the training is going according to plan, according to the best practices that we've already learned, so that the implementations are going off without a hitch, the workflows are implemented in the most efficient way possible for a given practice or health system. So it's really important, we found, that the workflow be right, that the users know what to expect, and our activation team is really in the process of perfecting getting that information out to the end users. So with that, I have a couple of slides to give you a demo of what complete EPA looks like in an EHR. It is a demo EHR. It's fake, but what you see here is the top part of the screen is where the native EHR would live, and the bottom part is what we call our accelerator. So at Surescripts, we developed a module that an EHR can plug directly into their native application. It opens up via an iframe, and at Surescripts, we've done all of the user interface and database work to make electronic prior authorization work. And basically, this lets an EHR roll out a full-featured electronic prior authorization solution at a fraction of the cost and time, so that we can, at the end of the day, drive more volume to the health plans and the PBMs. The accelerator itself is skinnable so that the user in the EHR won't necessarily know that they're interacting with a Surescripts user interface, but it really helps the EHRs to give a consistent user interface for their users. So what you're seeing here is a work list, and this part of the accelerator is just a list of all of the prior authorizations that are in process. And you can see the different tasks around the left-hand column. The first one being prior authorizations approved, the next one being complete prior authorization criteria. So a user clicking on that button will have the question set open up. And the questions are displayed one at a time so that we can take advantage of that skip logic. And the questions themselves are developed in a way that the data being sent back is usable and readable by a machine. This particular question is a radio button, yes, no. The user can only click one, and they can't click next until the information is filled in. So we're making sure we're doing validation that the information that you need is being sent to you, and it's being sent to you in a way that your machines can read it. So moving on to the next question, one of the things you'll see here is a progress bar at the top, here showing 33%. That's just a way to let the user know about how many questions they have left. And again, that's dependent on the number of questions that they're going to be skipping. So this particular question is another type of smart question, and another way that you get the exact information that you need. On a prior authorization form, one user might write in 8, the word 8. Another user might write in the number. But here in this specific case, what is being asked for is a number. The number here is 8, so the only thing we're going to let you put in is a numeric character that denotes the weight. So again, so that your database, it can be entered right into your database and acted upon. So clicking the next button goes to the end of the question set, and in this particular case, there's only 3 questions. And what we're going to do at the end is give the user an opportunity to see all of the questions that they answered, the answers to those questions, and here they have an opportunity to go back and change any answers or submit the question set back to the PBM. So this particular PA, if we go back to the screen with the work list, there's a task on there to acknowledge approval of a prior authorization. And this is what the approval looks like coming back from the PBM or the health plan. And here we see the information coming back that's important to the pharmacies and the doctor, and that's the prior authorization approval number. What EHRs are able to do when this message comes back is to take that authorization number and put it on a new RX so that when the pharmacy does get the new RX prescription, they're able to reference that a prior authorization was done, here's the new RX, and when they go to adjudicate the claim, they can include that as well. And here's a screen where we're tracking a prior authorization throughout its entire life cycle so that we can go back in, or the users can go back in and see who performed which task in the given prior authorization at what time. It's a way to give the EHR and the provider practice or health system an audit trail so they can track the prior authorization by step, see how long it's taken question sets, and what the final responses are. As you can see here, Mickey Mouse acted on this particular prior authorization. So that ends the provider perspective and the complete EPA demo. I want to turn it over now to Scott Furletti from Agadia to talk about the health plan perspective.
Thank you very much, Joe. I appreciate that. Thank you, everybody, for joining us this morning. And what I thought I would do is I'll keep my portion of it brief, just to give you an idea that PA Hub is a web-based solution that automates the end-to-end management of prior authorizations for health plans. And we do that for any type of healthcare service. Primarily today, we're in the pharmacy space or for drugs that are covered under the medical and the B versus D section of things. We do provide our services usable and is used today for all lines of business: Medicare, commercial, Medicaid, Taft-Hartley. And we receive requests from all channels: phone, fax, web, portals, and now EPA. And we've been doing EPA now for the better part of the year. As Joe had mentioned, once the NCPDP standard came out, we hit the ground running. Our CEO and leadership from Surescripts were key members of the team that developed the NCPDP standard and had been working on it for quite some time. I thought I'd give you an idea of where PA Hub fits in the system, in the process. So PA Hub resides in the health plan. We sit in the health plan system. We're software as a service, so folks don't know we exist. Providers don't need to contract with Agadia and PA Hub. So a real quick, easy three-step process. Once the prescriber submits the PA, Surescript would get it, process the request, submit it to the appropriate health plan and PBM, and now the health plan is going to use PA Hub to automate that decision. The process begins, the first step in the process begins with the e-prescribing networks and portals who will start the script. Those drugs requiring a prior auth would then be submitted to the health plan, where PA Hub sits, and we're going to check eligibility, reject codes with the PBM, where we're able to do that and get the clinical criteria appropriate for those reject reasons, the patient's benefit levels, and things like that. PA Hub, and I say PA Hub because the system is configured. These are taking out those manual steps. And again, as Joe mentioned earlier, a lot of the manual process up front, the loading of the membership, looking up eligibility, looking at things, that's all managed and done already as it comes into the health plan or the PBM. So PA Hub is going to interrogate if there's an ICD-9 or 10, drugs in history, what line of business they are, the demographics, their age, gender, where they live, where the insurance policy was sold, and some other items that we have. We're going to try to submit, we'll try to do an auto decision, meaning 30% of the requests that come in for PA today that we see are formulary. And the health plan simply wants to know, did they try something first? We're able to see that. PA Hub can see that by looking with a web service into the claims history. And if that's the case, we can make the decision right there and return that decision back to the provider. So that takes a great deal of labor out of the process. It takes all the labor out of the process for the health plan. It takes a great deal of stress out of the provider's office. If we can't make an auto decision based on the information we have, or if that information is not available, then PA Hub is going to send drug, line of business information, specific reject criteria questions back to the e-prescribing system via the Surescripts network. Those questions would then be presented to the physician in the physician's office, and this is instantaneous, so that the physician can now answer these questions on his or her tablet, computer, handheld, whatever they're working in to process these requests. And those criteria answers are then going to come back to PA Hub's decision engine at the health plan again, where the health plan has said what questions need to be answered in which specific way to get an approval or a denial. So once those questions come back to PA Hub, the answers to those questions come back to PA Hub, and all this still is 3 or 4 minutes worth of total time. If it can be approved based on the health plan's criteria, so if the patient has tried and failed something and their A1C is 10 and they weigh 65 kilograms and they live in California, then approve it, we're going to send a real-time authorization into the PBM that the health plan uses, or claims processor that the health plan uses. And then that status will be relayed back through the EHR, EMR, through the Surescripts network, so that the physician gets that immediate information. And this could happen while the patient's still in the physician's office. And then at the same time, PA Hub will generate the notifications for the health plan. The fax will go out to the physician, and the letters that need to be produced will be produced, and the health plan will manage those. If the recommendation comes back that this should be denied based on the way the questions were answered and the health plan's configuration, then what happens is PA Hub has a workflow, an automated workflow system sitting back at the health plan based on the health plan's configuration, and it'll move the work to those different queues, whether it's a pharmacist review queue, a nurse queue, medical director queue, even an external sign-off queue if a client has to make that decision for the health plan. Once that final decision is made, we'll relay that decision back through the EHR, EMR system and update the PBM systems as required. And again, at the end of that process, we'll generate those notifications that are required for the health plan to be in compliance either with CMS, Medicaid, NCQA, or contractual obligations that they have. So what does it all mean? So we can reduce the handle time of a prior authorization by 60%. A great deal of the handle time of a prior authorization is that manual process, looking up eligibility, looking at another system to find out what claims the patient has in history, generating letters, moving work, emailing folks. So 60% of the labor and time is removed from the process of handling a prior authorization using PA Hub, which leads to a 25% savings in administration costs. That total handle time certainly relates to member satisfaction. That turnaround and that quicker resolution makes the patient happy. From an EPA standpoint, the part we can't measure at this point is we know the traditional process that Joe went over in his presentation. The patient leaves the doctor's office. The doctor e-prescribes something to the pharmacy. The patient goes to the pharmacy thinking everything is okay. They see the pharmacist. He tells them, I need authorization from your health plan to get this. Now the pharmacist reaches out to the health plan. The health plan faxes the physician. Physicians at the end of the day or maybe the next day, depending on when that fax went, responds to the fax. That fax goes back to the health plan. Or until that original fax gets sent out, we don't know how much time. But for the patient, there's a day in there, maybe a half a day, maybe 2 days in that process. So that gets eliminated, even if that real-time decision can't happen up front, because at least the process is now already started and the health plan knows that it exists. And ultimately leads to prescriber satisfaction. The prescriber now gets something back in return for processing the PA through an electronic process. They're going to get an immediate response. They're going to have patient satisfaction. It'll cut out some of the bureaucracy of dealing with the prior authorization processes that exist today. From an overall statistic standpoint, PA Hub processes almost 4 million authorizations a year. That number has steadily grown. This year, in 2016, we'll process over 4 million transactions. And we're currently integrated with over 20 health plans. So we sit at these different health plans and PBMs. And we are at various stages of contracting, adding 6 new customers over the next 6 to 8 months into Agadia using PA Hub and some of our other solutions. A big push and a big reason in that is the EPA piece that we have today, the connectivity, that health plans are able to automate and retain local control and all the decision criteria and make their own criteria and manage their own criteria, make immediate changes to that they're able to meet CMS coverage determination and appeal guidelines with PA Hub and manage audits and produce all of their CDAG reports and everything else that's required to meet the CMS compliance. And overall reduce those administrative costs and turnaround times on handling. And what that leads to is the ability for a health plan to more than almost double their prior authorization volume without having to add additional staff. So that gives the health plan the ability to grow without having to worry about the human cost of that growth. And that really, at a very high level, gives an idea of where we are on the PA Hub side and where we fit into the EPA process. And really just in summary, we sit in the health plan. We contract, our contracts are with the health plans and PBMs, and we become the prior authorization system or the MTM system or adherence system, depending on what somebody has contracted with us for, to manage the entire process. And that's all I have, and I thank you very much for your time and attention.
All right, thank you. At this time, we're going to address some questions that came in during the presentation. Our first question is from Michael. I believe this refers to slide 8. What will the cost be and who pays? The physician practice or the pharmacy or the PBM?
So it's a good question, and the easy one to take here is the pharmacy. So for electronic prior authorization, really what we're trying to do is handle the prior authorization before it gets to the pharmacy. So there's no charge for the pharmacy. There's no charge for the pharmacy here. One pharmacy tie-in that we're making here is with RxChange. That's a transaction from the pharmacy to the EHR, to the prescriber in their EHR for retrospective prior authorizations. And what that RxChange allows the pharmacy to do is tie the request for a prior authorization to the new Rx that they received from the provider. And it allows the provider to respond to the pharmacy with a disposition. So letting the pharmacy know when the prior authorization has been approved, if it's been denied, or if they're canceling the medication and moving to another one. So RxChange is a really powerful message for the pharmacy to allow them some insight into the PA process itself. EPA is not a charge for the pharmacy, though. For the most part, the cost of the network, the cost of the EPA network, is being borne by the PBMs or the health plans. On the other side of the network, it's largely up to each individual EHR how they're going to roll it out to their individual customers.
And so from a PA Hub standpoint, we charge our fee is part of our agreements with the health plans and PBMs.
Okay, so then they're asking if it is approved and no PA is required, will it tell the doctor what the copay amount will be if they have patients that cannot afford, say, a $100 copayment?
Right, so not today. So EPA is really just communicating information back and forth on the prior authorization itself. Surescripts is working on a product that will do this, but it's not ready yet, and our EPA solution doesn't necessarily include this.
Okay, then how does the physician add the authorization number to the ERX?
That is done either automatically by the EHR, so that PA approval message is coming back into the EHR, and the EHRs are, for the most part, looking for that authorization number, and when it's present, they're putting it on the new Rx automatically. If the particular EHR isn't doing that, then the provider can go in, open up that PA approval message that we saw in the accelerator, and manually enter it into the new Rx field.
Now we have a different Michael asking a question. Have you studied the consistency between the EPA's submitted clinical information versus the actual EHR information? Are your providers accurate, truthful in their EPA submissions compared to the actual medical record?
So this is Joe at Surescripts, and we haven't looked at this. We hope the providers are being as accurate and truthful as possible. But really all we see on our network is the answers going from the EHR back to the health plans. We don't have any insight into what's actually in the medical records. And one of the things that we are working on right now is a way to extract more information automatically from the EHR so that an Agadia can ask a question a certain way with a certain tag in the code, and the EHR would see that tag and pull back a diagnosis code or pull back medications that have already been tried. So that's just one way we're trying to make it easier for providers to answer these questions, but we're not actually looking at that right now, the truthfulness.
Okay. Tricia is asking, she's saying, this is great, and is this being marketed to our providers? How do the providers enroll?
Yeah, so at Surescripts, we're marketing it to providers, and our goal in our marketing is to drive awareness. So we want providers to know that it's available through their EHR. They can ask their EHR for this functionality, turn it on, and start using it. And we're also working with EHRs to develop their marketing plans and help them on their rollouts to their physicians. We've done this a number of times now with a number of different EHRs. So we've learned a lot in the process, and we're trying to bring those best practices to the EHRs that are going live over the next couple of months.
Great. Our next question is from Jeremy. He says, the initial slides detailed how much time is involved in the PA processing. Clearly, the pharmacy benefits from reducing busy work, but doesn't this shift more of the PA workload to the prescriber on the front end? Many providers have nurses, MAs do much of the PA work currently. Is EPA available to accommodate the workflow like this?
Yep, absolutely, and totally agree that prescribers today are not processing prior authorizations, and if we develop a solution that requires them to do it, then they're not going to do it, and they're going to stick with the manual process. So we made it as flexible as possible in how they can process a PA, and our EHR partners heard the same message, and they made it as flexible as possible so that the PA initiation responses that are coming back from the PBMs and the health plans with the question sets are going into task lists that the provider practice can determine where they go. So if in their process today they have a central processing unit, like many health systems have, the prior authorizations are going there. If it's a nurse or a medical assistant, then the prior authorizations are going there. So it's really flexible in how it can be rolled out so that we make minimal changes to the prior authorization workflow.
All right. Scott asks, what is the typical level of effort and time to production to configure an EHR system to interface with Surescripts EPA web service?
So there are a couple of different ways an EHR can roll out this functionality with Surescripts. The first would be native, what we call native, and that is the EHR developing the entire set of functionality. There are 8 different message types in the EPA standard, so the EHR would have to develop to all of those, stand up a database to track those messages behind the scenes, and develop a user interface. What we've done at Surescripts is develop that accelerator that we saw in the slides earlier that handles the user interface for an EHR and handles 7 of the 8 EPA messages so that the EHR can stand it up relatively quickly. And the time to production really depends on the amount of resources that an EHR has to devote to an EPA product. We've seen anywhere between 1 month and 5 months between starting the project and going live.
Jamie asks, which EHRs does this not work with today?
It's a good question, and it will work with every EHR that goes through implementation with Surescripts. It's right now just a matter of bringing those EHRs through the process. So there's a contracting process and then the implementation process to roll it out. Where we are right now is about EHRs representing about 465,000 e-prescribers. So that's somewhere around 70% of the e-prescribers have complete EPA in their EHRs today.
Okay, thank you. That's all the questions we have at this time. So, gentlemen, I'll turn it back to you for closing comments.
So this is Joe Delisle, and I just want to thank everyone for the time today, for learning about electronic prior authorization. And if you have any questions or comments on Complete EPA, then please send an email to either Garrett Ianella or Ron Tyson, whose email addresses are on the slide. So again, thank you.
And I would also like to thank you on behalf of Agadia, myself. And if you have any questions for Agadia, you can contact us with the email shown on the screen there, or you can contact me directly. My information is available on our website as well. And I look forward to speaking with some of you and meeting many of you at the upcoming conferences.
Thank you for that great presentation and for sharing your thoughts today. Thank you to the audience for participating in today's conference. That concludes this webinar. Thank you again, and enjoy the rest of your day.